I'm going to be sharing the last presentation with my colleague, Scott Decker. Scott and I are going to both present different AJIC NHSN case studies that have been published and are still available on the web. So we're hoping that this presentation will give those of you that haven't actually tried these case studies a sense of what they're like. And so could I just see a show of hands? I know I asked earlier how many people, but now that we're down, how many people here have actually done an NHSN case study from AJIC? Very few. Okay. As I had mentioned, you are able to go online and answer the questions, and then you'll get a score, and you'll actually get the rationales and the correct answers. So without further ado, we'll go ahead and get started. I'm going to be presenting a case study that was titled Respiratory Illness and Positive Blood Cultures, What's the Correct Determination? And so we're going to review the case. We'll be using poll everywhere, and hopefully it will cooperate. We'll go over the answers and rationales, and then we'll answer questions if we have any. And we'll do questions for this one. We have an hour, so we'll take 30 minutes for this case if we need it, and then Scott will have 30 minutes also for his. So I just want to start by saying that this is a judgment-free zone. So don't be afraid to say an answer if you're not certain, give your best guess. We're all here to learn, and if it was an easy case, it wouldn't be in the journal or it wouldn't be available. We specifically write these cases to address some of the most frequently asked scenarios that we get, or some that we think are a little bit more complex, and so it's not necessarily a simple case. So you should have in your resource manual, under today's date, you're going to have the case and questions, and also you'll have available, I provided to you the secondary bloodstream infection rules, scenario 1 and scenario 2, so you don't have to pull it from memory. And you also have the pneumonia checklist that you can use, which will be very helpful. So the case is on March 9th, an 18-year-old patient with cystic fibrosis is admitted to a pediatric medical ward. Coarse breath sounds are heard over the right upper lobe of the lung. O2 saturations are at 86%, and the patient has started on oxygen therapy at 4 liters per minute. Chest x-rays collected on admission show diffuse bilateral bronchiectasis, worse in the right upper lobe, with parenchymal opacities in the right upper lobe, which may represent atelectasis, but most likely represent superimposed pneumonia. The left lung is clear. The patient's white blood cell count is elevated at 16,000 cells per millimeter cubed. On March 10th, the next day, the patient develops a fever of 101.4, and pulmonary crackles are heard over the upper right lung. Sputum, which is now blood tinged, is collected for culture. The patient is tachypnic and is placed on a conventional mode of mechanical ventilation. So this guy really went downhill. On March 11th, fever, crackles, and tachypnea continue, and the patient is coughing up large amounts of green sputum. FiO2 settings range between 30 and 100%. A triple lumen catheter is placed in the subclavian vein. So again, that's March 11th. That's the 3rd day of admission. On the 12th, the sputum culture that was collected on the 10th is reported as positive for Staph aureus and Pseudomonas aeruginosa. On March 13th, they collect another chest x-ray, and it shows an increased confluent opacity in the right upper lobe, and the radiologist states that pneumonia is likely, and the patient remains on mechanical ventilation. So here is your first question to consider. Which of the following is most true? The patient meets pneumonia 1 criterion, clinically defined pneumonia, date of event on March 9th, and the event is not ventilator associated. The patient meets pneumonia 1 criterion, clinically defined pneumonia, date of event on March 9th, and the event is ventilator associated. The patient meets pneumo 2 criterion, pneumonia with common bacterial or filamentous pathogens and specific lab findings with the date of event on March 10th. Or D, again, they meet new 2 criterion with a date of event on March 12th. So we'll give you a little time to think about that and to come up with your answers. Again, feel free to use your checklist that we've provided for pneumonia. All right. Let's see what we have. So we've got a little bit of a split decision here. Can't see that. 72%. 72% of you think that this is a pneumonia 1, which is a clinically defined pneumonia on March 9th, and that the event is not ventilator associated. And then 21% think that this is a pneumonia 2 criterion, a pneumonia with common bacterial or filamentous pathogens and specific lab findings with date of event on March 10th. And then a couple of other people think the other options also. So I'll show you what the correct answer is. Drum roll. Correct answer is A, so congratulations. The majority of you got that correct. And let's go ahead and talk about why this is. So first, as is always the case in multiple choice, let's rule out our possible answers. The pneumonia 2 criteria require specific lab findings of pneumonia, and let's look at what they are. It requires either intracellular identification of bacteria from bronchial alveolar lavage. Do we have that? No. Histopathologic findings of pneumonia, an abscess with polymorphonuclear consolidation in bronchioles. I know that's not right. And alveoli. Lung parenchyma by fungal hyphae or pseudohyphae. We have that? No. PMNs. How about an organism identification from blood, pleural fluid, lung tissue, or minimally contaminated lower respiratory tract specimen? No. Correct. And that may be where a couple of you may have thought maybe the sputum was a minimally contaminated lower respiratory tract specimen, but it is not. What would be included would be BALs, protected specimen brushing, or endotracheal aspirate. And this person was just coughing this up. So in this case, we don't have the information that it was collected in either by protected airway endotrach or tracheostomy, or so we can't use it. So neither answer C nor D can be correct, right? C or D can't be correct because those are both pneumonia 2s. The chest x-ray is interpreted as likely pneumonia on March 9th, which sets the IWP from 3.7 to 3.12. And in this case, the IWP is shortened by 1 day because it involves the POA time period, which is limited to the 2 days before admission. Note that only one of the elements marked with an asterisk are required to meet the pneumonia 1 criteria, while 2 of the elements that are marked here with a caret are required. And this patient had more than enough of what was required. And for those of you that are not familiar or not aware, Rails are also described as crackles. So if you see crackles documented, you can consider that those are rails. Note also that the second required imaging test for pneumonia, because this patient had underlying pulmonary disease, right? He had cystic fibrosis, needs to fall within 7 days of the first, which it does in this case. The patient meets pneumo 1 criteria with a date of event on March 9th. Okay. So even if the patient had pneumonia 1 elements in the 2 days before admission, which is part of the POA timeframe, just remember that the date of event would still be the date of admission. Remember, way back on Monday, which you probably all forgotten by now, we talked about that if the date of event occurs before admission, so you have a symptom of or an element present, let's say the day before. In this case, we had something from the day before. I don't remember if it was cough or what it was, but that we don't use anything before admission to set the date of event. We started on the date that the patient is admitted in that case. Okay. This is just another way to look at the requirements that we have, and I've identified here for you, what they were. We had new and persistent, or in this case, it was new and persistent, positive chest x-ray for an infection, had a fever, we had leukocytosis, we had a change in the character of the sputum. Remember, it became green at one point and bloody, and the patient had tachypnea and new onset of cough, rails, which in this case they described as crackles, and increased oxygen requirements that was exhibited by them having to start him on oxygen. Okay. We did want to make one note that coarse breath sounds are not equivalent to bronchial breath sounds. For those of you that aren't aware, breath sounds heard over the tracheobronchial tree are called bronchial breathing, and breath sounds are heard over the lung tissue are called vesicular breathing. Bronchial breathing anywhere other than over the trachea, the right clavicle, or the right interscapular space is abnormal and are noted as bronchial breath sounds. And there are some really good online, there are actually some really good educational type videos and auditory things that you can Google and listen to. I've done it myself, and they have some really good ones out there. Okay, so the rationale, the patient was not ventilated for more than 2 days on the date of event. Therefore, it's not a ventilator-associated pneumonia. And answer B is correct. Now, even though this patient is 18 years old, he is housed in a pediatric location. I don't know if you noticed that or not. And therefore, if your facility is doing PEDVAP surveillance in your monthly reporting plan in that location, that patient, even though they're 18, would still be eligible for PEDVAP surveillance. Okay, we do surveillance by locations. All right, the case continues. On March 15th, the patient's WBC remains elevated at 14.8. The next day on the 16th, the rails are again documented. The patient's temperature increases to 103.1, and blood is collected for culture. The patient continues to have thick, creamy, now green sputum. Actually, it was green, I think, the day before. A follow-up chest x-ray shows continued dense opacities in the upper lobe of the right lung. And on the 17th, the blood culture is reported positive for Staph aureus. So you know what we're going to ask. Does this patient have eclampsia with Staph aureus? And you can say yes, A, they have eclampsia with the date of event on March 16th. Or yes, they have eclampsia with the date of event March 17th. No, the bloodstream infection is secondary to pneumonia 1. Or no, the BSI is secondary to pneumonia 2. Okay, we have almost as many answers as we did for the first one, so just a few more seconds. All right, let's see what we have. Oh, we are split. So most people think it's a pneumonia 2 with a secondary BSI, but some people say that it's a bloodstream infection that's secondary to pneumonia 2, or pneumonia 1, I'm sorry. And a smaller amount say it's eclampsia with the date of event of March 16th. So can you have a secondary bloodstream to pneumonia 1? No. So we know that C cannot be correct. So what can be the correct answer? Correct answer is D. The BSI is secondary to pneumonia 2. I see hands in the air back there. Rocky. I see the Rocky hands. So let's go on to look at the next question before we discuss the reasons for the answers of because I think that'll be easier. So the next question is, what is the date of event and the repeat infection time frame for the pneumonia event now? What is the date of event and the RIT for the pneumonia event now? So you can say the date of event and repeat infection time frame do not change. Or the date of event for pneumonia 2 is 3/10 and the RIT becomes 3/10 through the 23rd. Or the date of event for pneumonia 2 is 3/13 and the RIT becomes 3/13 to 3/26. All right, let's see what we have. We're split again. This is a good case. Almost half of you think that it's A. The date of event and the repeat infection time frame do not change. And then the other 50% is split. And the good news is that the 48% are correct. And so the repeat infection time frame and the date of event do not change. Okay, so let's explore the answers. The pneumonia 1 sets a pneumo repeat infection time frame on March 9th, correct? Through the 22nd. During the RIT and the secondary BSI attribution period, or SBAP, a positive blood culture is collected with Staph aureus and the patient continues to have symptoms of pneumonia. It's reasonable to consider that the patient may still have pneumonia and the BSI is secondary to that. Pneumonia 2 and pneumonia 3 are the only pneumonia criteria to which a BSI may be secondary. However, one of the two secondary BSI scenarios must be met. Scenario 1, the blood specimen must be collected during the pneumo secondary BSI attribution period and match at least one organism from an eligible site that was used to meet the pneumo criterion. Or scenario 2, the blood specimen organism must be used as an element to meet the pneumo criterion. Since there is neither an eligible specimen, remember we said we couldn't use the sputum, we didn't have a BAL or lung tissue or anything else, from the respiratory tract, scenario 1 cannot be met to account for the BSI. That means in order for the BSI to be secondary to pneumonia, secondary scenario 2 will need to be met, and identification of an organism from a blood specimen collected during the pneumonia's infection window period must be part of the pneumonia criteria that is met. The chest x-ray interpreted as continued evidence of pneumonia on the 13th sets the IWP 310 to 316. All elements of the pneumonia 2 criteria definition to include the blood culture are captured in the IWP, and the date of event for meeting pneumonia 2 is within the pneumonia RIT. Note that only one of the elements marked with an asterisk and the caret are required to meet pneumo 2, and that's because we also have laboratory supporting evidence. So we, instead of requiring 1 and 2, we only require 1 and 1 plus the lab result. Remember that BSI, UTI, and pneumonia RITs are applied at the level of the major type of infection, right? Not the subtypes or specific types. And only one pneumo is reported during an RIT, but more than one specific type of criterion can be met in the RIT. And in this example, meeting another criterion accounts for a secondary BSI. So what I always say to people to help them remember is that you have, in this sort of a situation, the patient met criterion 1 early on, but later on they also met a pneumo 2 criterion. And how could we defend if we said to you, well, you can't account for that blood, even though they met a criterion that accounted for the blood, right? Wouldn't be fair. So we recognize that, and this actually, happens. People's pneumonia gets worse sometimes, and they'll then have a positive blood specimen. Okay. So the takeaways and the additional pearls, sometimes infections linger and may progress to include a secondary bacteremia, so always consider other criteria. If there is a BSI that which you believe may be secondary, consider criteria of the same infection type or other infection types. See if they meet another criterion for that same type of infection, or they meet another type of infection. The pneumonia definition can be used for secondary BSI attribution when conducting BSI and CLABSI surveillance for all patients, regardless of whether they're ventilated, and also regardless of whether or not you're doing VAE surveillance in that location. So patients for whom the VAE criteria does not account for a BSI, consider the pneumonia criterion as a primary cause and look to that criterion to see if that can account for it. And the repeat infection timeframes and secondary BSI attribution periods do not roll forward. One must end before another is eligible to begin for the same type of infection. And these were the same types. They were both pneumonias. Published case studies like this are tools for confirming the accuracy of surveillance within a facility. This is a link to the open access site if you don't have an AJIC subscription. And give yourselves a hand. Woohoo! And now Scott's going to come up. Hopefully we'll have time for questions at the end, or I'll be available.
All right, well, hello again, everyone. We're going to transition over to a location mapping study from the AJIC studies. Again, my name is Scott Decker, and like I said at the beginning of the week, one of my main focus areas on the methods and analytics team is location mapping. So if you've had any interaction with me in the past via email, it's more than likely been revolving around a location question that you may have had for one of your units or multiple units on your facility. And this presentation, this case study, was really born out of all of those questions that I've received over the past 3 or 4 years. And I think our reason why we don't spend a lot of time covering locations at this NHSN training is that we acknowledge that no two facilities are the same when it comes to location mapping. So it's really hard to provide a really ubiquitous examples with locations without there being questions or small nuances in a facility where what we're talking about doesn't really fit everyone's scenario. So I think what we're going to see today in these case studies is that there are going to be scenarios that are going to be applicable to your facility, and you're going to be able to apply some of these rules or some of these definitions to your facility. So what I want to get across today is defining unit accuracy according to the established criteria. So mainly what I'm talking about there is the NHSN 80% rule, which I'll go over in a moment before we get into our case studies. I think help determining service type for locations with mixed populations. So there's very rarely we have locations where every single patient meets the same acuity level and service type. So what do we do when we have a diverse patient population, and how do we map to the most specific location as possible? And finally, how do we manage interim physical relocations in NHSN? So this is locations that may be temporarily closing, that could be all moving and shifting for a temporary period of time. So we'll cover that too with one of our questions. And finally, I just strongly recommend that you review and reference the following section from the NHSN protocol, chapter 15 on the locations chapter. So most of the answers I give today are going to be found in that chapter. So yeah, with that being said, I think we're gonna get right. Actually, no, I've wanted to go over one rule to help you before we get into the case studies, and that's the NHSN 80% rule. So this translates, what this rule is it translates that the requirement they give it for a given location that 80% of patients share a common acuity level. So it's like a critical or a ward level status, or maybe a step down unit. Similarly, subspecializations like orthopedic, neurosurgical, medical units requires 80% of those patients as well to be admitted to locations share the same specialty service type. And finally, services may be combined into more generic categories such as neurosurgical, cardiac surgery, or general surgery, combined to a total 80% and being categorized as surgical. So if you have several different surgical categorizations, they can kind of be rolled up to a larger just surgical category, or a more broader surgical category. We will not be using poll everywhere for these questions. You'll see in a minute. I don't use all true and false and multiple choice. So follow along in your resource guide. I think the questions start on page 96 in your guide. So you can turn there and follow along on those pages. The first question I have, and again, this is not going to be like a chronological case. There's going to be 5 independent questions and scenarios for location mapping. So question number 1 is rank the following methods for determining patient acuity. So critical care versus non-critical care from 1, that's best, to 5, worst. Ask the nurse manager, medical director for consensus to the question, are 80% or more of the patients requiring blank acuity level, and approve the designation through the infection control committee. Option B, retrieve recent patient acuity billing data for a year. If 80% or more of the patient days in this unit is billed at the same acuity level, such as a critical care unit, map the unit to the same acuity level. C is retrieve recent patient acuity billing data for a month. If 80% or more of the patient days in the unit is billed at the same acuity level, map the unit to the same acuity level. D is if the unit is called an ICU within the organization, it is a critical care unit. If it's called an ICU, it is not a critical care unit. Okay? And the final option is review the admission transfer diagnosis for admission to the unit for a year and determine the acuity on admission. If 80% or more of the diagnoses indicate that the need for critical care, map the unit as a critical care unit. So I'll give you guys a few minutes to rank these in order from best to worst. How's everyone doing? More time? Is everyone, can I get some thumbs up, thumbs down? Everyone good to go? Want to see the answers? All right. So the best, number 1, retrieve recent patient acuity billing data for a year. So if 80% of those patient days are of a certain acuity level, you're going to map to that. That's the best option. Second, review the admission transfer diagnosis for admission to the unit for a year to determine the acuity on admission. So this is very similar to number 1. You're just looking at admission or transfer diagnosis over the acuity billing data. Third is retrieve recent patient acuity billing data for a month. If 80% or more of the patient days is billed at the same acuity level, you'll map to that one. Again, not looking at quite as much data or a year there, so that's why it's fallen a little bit farther down the list. Number 4 is ask a nurse manager or medical director for a consensus to the question. And finally, the worst option is if the unit is called an ICU within the organization, it must be a critical care unit, right? Not always the case. So that was our 5th worst. So we'll go over some of the rationale why those rankings were where they were. So just to start off with, ideally facilities should review a patient mix for a unit for at least one full calendar year if possible. And given that, so if acuity billing data is available, it's the most reliable and most objective method of determining acuity. However, we know that's not always possible to retrieve that level of information for certain facilities. So we say the next second best option would be to look at admission diagnosis for a particular unit. So again, if a year is not available, and just a shorter period of time of at least 3 months is acceptable, but every effort should be made to collect and analyze a greater time period in the future. Again, if your unit's only been open for 3 months, or if it's relatively newer or less than a year old, you got to use the data that you have. So I would just suggest in that situation just to continue to monitor your patient breakdowns for the next 3 to 6 months to make sure that you've accurately mapped the unit. And finally, again, if your unit is brand new, consensus of clinical leadership, although it's suboptimal, may be the only option. In that case, it would be acceptable when trying to establish the CDC location description for a brand new unit. And again, I think we were laughing at, we know that to name a unit as determined by the organization themselves without any kind of further input lacks a lot of validity. So we, highly suggest and recommend this is not one of the options facilities take when determining a location type. All right, moving on to question number 2. A given unit has 60% adult critical care and 40% adult ward patients as determined by a year's worth of admission diagnosis data. Of the following, which is not an acceptable choice to designate a location in NHSN? So here are your four choices. Reanalyze the data using an equally acceptable but alternate measure, such as billing data. And if this analysis reveals a single acuity level for greater than 80% of the patient population, map to that acuity level. Option B is map the acuity as adult critical care because 60% is the majority. Option C is map this as a mixed acuity location. Or D, split the unit into 2 virtual locations. Yeah, so which is not an acceptable choice? All right, I'm hearing B. Let's see. Yes, B is the correct answer because why? That's right. It doesn't meet the 80% rule. Just because you have a majority of 60% adult critical care patients, we don't actually meet the NHSN 80% rule. So mapping this unit at 60% for adult critical care wouldn't be accurate. Again, the rationale we're using here. So if you ultimately use a different method to determine the unit breakdown, that you determine that it's not definitive. Alternative data, they're acceptable. It may be suboptimal, but that's an option to maybe get closer to the truth of what type of patients you have. However, that might not be an option for you. You may choose to create 2 virtual locations, which if properly mapped can be reported separately and allow that reporting and benchmarking for 2 or more locations. And finally, mixed acuity locations is also acceptable. But again, benchmarking efforts are more heterogeneous and may not offer a benchmark as comparable as virtual locations because you're running into a less specific unit type where if you have critical care patients and ward level patients, your mapping is mixed acuity. There's just a lack of specificity. There's just a really broad level of risk there between those patient types, and that's accounted for in the benchmarking for mixed acuity unit. So just a word on virtual locations. So this is you can use this and create an NHSN when a facility is unable to meet an 80% rule for location designation in a physical single unit, but would like to report their NHSN surveillance data for each of the major specific patient types in that unit. So in this last scenario, we had 60% critical care and 40% ward patients. In that scenario, we can't map one location to a specific unit type. You could opt to map 2 virtual locations where you delineate the number of beds for your 60% critical care patients and map them just to 1 unit, and then take that next group and delineate their bed types for ward level patients and map an appropriate ward level location for NHSN. So while it's recommended that virtual locations can be used when a location can be geographically split, maybe like a wall or some kind of double doors, it's not the requirement to map a virtual location. To use virtual locations, we ask that unit staff will need to be able to identify specific beds that are used for all patient types that are found in that area. So this is done in order to assign them to be correctly mapped to a CDC description code. So this is easiest. This is probably only advisable if there is some kind of physical delineation, or there's some kind of separation of when you know beds 1 through 10 are this type of location, and beds 11 through 20 are another type of location. And that's a good way to split them in half and have two separate virtual locations. Question 3. A given unit comprises of 50% cardiac surgical critical care, 20% surgical critical care, 20% oncologic surgical care, and 10% medical ward patients. Of the following, which is not an acceptable mapping choice? A, surgical critical care with a medical ward patients included. 2 separate virtual locations with 1 surgical critical care for 90% of their critical care patients, and the second one being the medical ward for 10% of the medical non-critical care patients. So those are your ward patients. Option C is 2 separate virtual locations for 1 cardiac surgical critical care. And number 2, surgical critical care comprised of the 40% of surgical critical care patients. Those are your oncology surgery and just your general surgery critical care patients, as well as the inclusion of the 10% of the medical ward patients. And finally, the last option is a medical surgical critical care unit. All right, does anyone have an answer they want to share? I hear D. I heard D, right? D as in David. All right, everyone's saying D. That's correct. Good job. All right, so some of the rationale here. This unit's population comprises of 90% critical care and 90% surgical services. So, like I said, when we apply the NHSN 80% rule, you first apply it to the acuity level, and then you cascade down and apply it to that service type. So when we do that, we establish that 50% cardiac surgical critical care plus 20% surgical critical care and 20% oncological surgical care gives us 90% of the same acuity and 90% of a specialization of surgery. So if you just select a general surgical critical care unit, that can also be acceptable in this definition because you meet that definition by selecting the lowest common denominator when it comes to subspecialty. Okay, there's also opportunities. There's different opportunities for you to map 2 or more virtual locations in this scenario, and that's just based on if you're able to delineate certain beds for those subspecialties. So, for instance, you can create 1 virtual or 3 virtual locations. The first one comprising of 40% of just surgical critical care patients in one area. The second having 20% cardiac surgical critical care patients. And then the third location, you can have 20% of the oncological surgical critical care patients as well. In any of those situations too, it's just because you have the majority of those patients are going to be surgery, you can include those ward level patients if there's beds are located within that area, because there's such a low number that they're not going to lower your past that 80% threshold. So in addition, just mapping 10% of medical ward patients separately as its own virtual location, it's allowable, but we really only recommend it if benchmarking that medical ward is deemed an institutional priority. So, if you're able to separate those patients out by their bed type and you really want to map and really want to account for those medical ward patients specifically, you're able to do so with virtual locations. But however, again, like I said, if you included them in any of those other virtual locations that had those cardiac or had those critical care patients, that's allowable as well because they're not going to compromise lowering beneath the 80% rule for those critical care units. All right, question 4. An inpatient location for level 3 neonatal critical care unit is located on the 3rd floor, and you've labeled it in your NHSN location manager as NICU 3, which is currently part of your reporting plan and is being temporarily relocated to the 4th floor with no existing label. While the 3rd floor location is being remodeled, construction is expected to last 6 months. The patient type and bed size will remain the same. Which method or methods can you use to continue to report data for this mapped unit in NHSN? Here are answer options. The first one is change existing location, your code, to match the new code assigned. So an example could be changing it from NICU 3 to NICU 4 on the day of the relocation and change it back to the original label as NICU 3 on the day that the unit returns to its original physical location 6 months later. Option B is create a new location code and location type NICU 4, level 3 NICU, and inactivate that old NICU 3 unit from NHSN temporarily. And so when that unit reopens, you can inactivate NICU 4 and reactivate NICU 3 and re-add it back to your monthly reporting plans. Option C is either the above. Option D is neither A nor B. I'm hearing C from some folks. Is that what everyone's thinking? C? I hear C and D. Okay, let's see. It's C. Either of the above. All right, so what you can do here, option A. So what happened in here? If you choose option A, this ensures that data from this unit will not be interrupted with only just modifying your code unit or your code label as opposed to creating a newly mapped unit. So if you've been adding a bunch of historical data to this, if you have a bunch of historical data to this unit that you don't want to lose, you want to continue to trend, just change that label because the properties of the location aren't changing, your patient types aren't changing. So if it's all just physically moving, you can just simply change that code and it's not going to compromise that CDC location description that you use for benchmarking. So you continue to follow those past patients, those past months, and have them incorporated there by just changing your code temporarily. Conversely, you can also do option B. So you'd have to adjust your monthly reporting plans. You have to complete more actions in the locations manager with adding a new location, inactivating a location, and then doing that whole process again once that location is restored to its original physical space. But either option is allowable. And then NHSN. All right, our last question, then we'll get out of here. Your acute care facility performs fact-wide in-reporting for lab ID events and owns and operates 2 separate off-site emergency departments which admit patients to your acute care facility. Of the following mapping, which is not acceptable? Option A is map each ED location separately using the CDC location code, out acute ED. Map the emergency departments together as one off-site ED using the CDC location code, out acute ED. Or C, do not map these ED locations to the acute care facility. So I hear someone whispering C over here. All right, C is growing louder. Okay, let's see if that's what it is. All right, it's C. Do not map these ED locations to the acute care facility. So again, each emergency department affiliated to the acute care facility, even if it's off-site, we're almost done, guys. Hold on. Facilities should be mapped for location attribution and lab ID event reporting. If the acute care facility combines visit information for the 2 off-site emergency departments, it's allowable to map these as a single location for reporting purposes. So you can just have one ED location mapped to NHSN for that one facility and have all that data, all those encounters aggregated for lab ID. Otherwise, you can just simply map those 2 locations as separate EDs within that acute care facility. All right. I think that's all I have for my questions for you. We're ready to go. I know Kathy didn't have an opportunity to answer any questions. If you guys had from the audience, if you have from me or for Kathy's cases, we can take those at those time.